In this video, we will explore the anatomy of the carotid system, focusing on its structure, course, and clinical relevance. To do so, we will start by a brief introduction, followed by detailing the descriptive anatomy and branches of the common carotid arteries, the external carotid arteries, and the internal carotid arteries. We will explore some clinical applications, the surgical approach routes, and finally a conclusion to summarize all the key points. The carotid system plays a crucial role, providing arterial blood supply to most of the face, neck, and brain. Let's start by detailing the anatomy of the common carotid arteries. There are two common carotid arteries: right and left. The left one arises from the convexity of the aortic arch, whilst the right one arises as a terminal branch of the brachiocephalic trunk. They project along a line from the sternoclavicular joint to the neck of the mandible. Both end by dividing into the external and internal carotid arteries at the level of the upper border of the thyroid cartilage. Moving on to the anatomical relations of the common carotid arteries. In the thorax, only the left common carotid runs through this region. It is related to the following structures. Anteriorly, the left brachiocephalic vein. Posteriorly, the esophagus. The left subclavian artery. The thoracic duct. To the right, the brachiocephalic trunk and the trachea. To the left, the vagus nerve and the left phrenic nerve. In the neck, the right and left common carotid arteries are related to. Anteriorly, to the sternocleidomastoid muscle and the superior belly of the omohyoid muscle. Posteriorly, to the prevertebral muscles and the sympathetic trunk. To the left, the arch of the thoracic duct. Medially, the trachea, the esophagus, the larynx, and the thyroid gland. Laterally, the vagus nerve, the internal jugular vein, and the phrenic nerve. Let's detail now the external carotid arteries. The external carotid arteries supply the anterior regions of the neck, the skin of the face, and the head. They arise from the common carotid artery at the level of the upper border of the thyroid cartilage. They are anteromedial to the internal carotid artery. Then, they ascend vertically for about 2 centimeters, before inclining laterally and posteriorly to become lateral to the internal carotid artery. They end below the neck of the mandible, giving rise to the superficial temporal artery and the maxillary artery. The collateral branches of the external carotid arteries are the superior thyroid artery, the lingual artery, the facial artery, the occipital artery, the posterior auricular artery, and the ascending pharyngeal artery. The superior thyroid artery arises near the origin of the common carotid artery. It lies against the inferior constrictor muscle of the pharynx and ends in 3 branches: the infrahyoid branch, the sternocleidomastoid branch, and the superior laryngeal artery. The lingual artery arises above the superior thyroid artery. It follows the lateral muscular wall of the pharynx, and it ends in the deep artery of the tongue and the sublingual artery. The facial artery arises above the lingual artery at the level of the greater horn of the hyoid bone. It passes under the belly of the digastric muscle. Then it loops around the submandibular gland. It lies against the mandibular angle before becoming subcutaneous in the nasolabial groove. It ends at the internal angle of the eye, giving off the angular artery, which anastomoses with the dorsal nasal artery, a branch of the ophthalmic artery. The collateral branches of the facial artery are the superior and inferior labial arteries, the sublingual artery, and cutaneous arteries for the facial skin. The ascending pharyngeal artery arises above the lingual artery and terminates in the lateral pharyngeal wall. The occipital artery arises from the posterior aspect of the external carotid artery. At the level of the facial artery, it follows the posterior belly of the digastric muscle towards the occipital bone. It ends at the occipital scalp, dividing into two branches, one medial and the other lateral. The posterior auricular artery arises above the posterior belly of the digastric muscle. It follows a vertical course behind the auricle, and then it divides into two branches, the auricular branch and the occipital branch. Let's move now to the terminal branches of the external carotid arteries. The superficial temporal artery supplies the frontoparietal scalp. It arises from the external carotid artery and emerges from the parotid gland. At its origin, it runs vertically, preauricular, near the temporomandibular joint. It ends in two branches, one frontal and the other parietal. The maxillary artery is a deep artery. It supplies the maxillomandibular and nasal bones, and it arises behind the neck of the mandibular condyle. It passes through the infratemporal fossa, then the pterygopalatine fossa, and makes contact with the trigeminal nerve. It ends in a terminal branch, the sphenopalatine artery, which supplies the nasal cavity. The collateral branches of the maxillary artery are the posterior pterygopalatine branch, the ascending branches, that are superior maxillary and infraorbital arteries, and the mandibular and masseteric arteries. Let's tackle now the descriptive anatomy of the internal carotid arteries. The internal carotid arteries arise from the common carotid artery at the level of the upper border of the thyroid cartilage. They ascend vertically for about 2 centimeters, then incline medially towards the lateral masses of the atlas. At this level, they pass through the carotid canal and the cavernous sinus. The internal carotid artery has 4 segments: the cervical part, the petrous part, the cavernous part, and the cerebral part. Let's explore the anatomical relations of the internal carotid arteries on each of their parts. Starting with the cervical part. It is located within the carotid sheath and in relation with anteriorly and laterally. Below the digastric muscle, it is in relation to the sternocleidomastoid muscle. At the level of the digastric muscle, it is in relation to the stylohyoid muscle, the occipital artery. And above the digastric muscle, it is in relation to the glossopharyngeal nerve. Posteriorly, it is related to the cervical sympathetic trunk, the longus capitis muscle, and the internal jugular vein. And medially, the pharyngeal wall. The petrous part passes through the carotid canal, then emerges from the canal. It traverses the medial part of the carotid canal, passing between the lingula and the body of the sphenoid. The cavernous part is located within the cavernous sinus. It is related to the oculomotor nerve and the trochlear nerve. The cerebral part passes through the roof of the cavernous sinus. It is in relation, medially, to the optic nerve and optic chiasm, and laterally, to the anterior clinoid process. The cavernous part gives several branches. Branches to the cerebellar tentorium, branches to the cavernous sinus, and the inferior and posterior hypophyseal arteries, supplying the posterior lobe of the pituitary gland. The cerebral part gives the following branches: the superior hypophyseal artery, destined for the pituitary stalk and the inferior part of the hypothalamus, and the ophthalmic artery, that travels anteriorly to the optic canal, below the optic nerve. It terminates at the medial angle of the eye. The collateral branches of the ophthalmic artery include the central retinal artery, the lacrimal artery, the supraorbital artery, the long posterior ciliary arteries, and the anterior ethmoidal artery. And its terminal branches are the supratrochlear artery and the dorsal nasal artery. The terminal branches of the internal carotid artery are the anterior cerebral artery, which supplies the medial portions of the frontal lobes and parietal lobes of the brain, and the middle cerebral artery, that is the largest branch of the internal carotid artery and supplies the lateral aspects of the frontal, parietal, and temporal lobes, as well as the basal ganglia and internal capsule. Let's discuss now some clinical applications. Carotid thrombosis is a serious condition that can lead to strokes and other severe neurological consequences. The main factors influencing its development include atherosclerosis, hypertension, smoking, diabetes, and a sedentary lifestyle. Diagnosis is made through imaging studies, and treatment can involve medications, endarterectomy, or angioplasty with stenting. Surgical approaches, such as oblique or longitudinal incisions, are used in cases that require direct access to the carotid artery. The approach techniques to the carotid arteries are two. First, the oblique incision, presternocleidomastoid muscle, provides access to the common carotid artery, its bifurcation, and the internal jugular vein offers a clear view for carotid artery procedures like endarterectomy. And the longitudinal incision, between SCM heads, allows access to the carotid bifurcation and deeper structures and is ideal for more extensive procedures or when revascularization is needed. To conclude, the carotid system plays a crucial role in supplying blood to the head and neck. It consists of the common carotid arteries, which bifurcate into the internal and external carotid arteries, each with distinct paths and vascular territories. Understanding their anatomy is essential for both clinical practice and surgical procedures involving the cervical region.